This is a special presentation from the Brighton Central School District PTSA.
We are now going to go to our presentations, and I'm going to turn our time over right now to Dr. Mendoza. Thank you.
Thank you. Well, good evening, everybody. It's a pleasure to be here. As I was saying earlier, I'm a Brighton parent. I've given talks in half a dozen of the school districts around the county now, and it's good to be home. My kids are in 7th and 4th grade, and I asked them before I came here, do you want to come to the talk tonight? And they said, no. I guess we know where their priorities are. So tonight I'm going to talk about the opioid crisis. We can't cover nearly all of it in 15 or even an hour. But my hope tonight is to open up a conversation with all of you with the intention of continuing this conversation at another time. As you all know from the news, from the media, from local, national media, this is an epidemic. And I'll explain a little bit about what that means. But in a nutshell, this is a problem that is really stepping up. And we need to get our arms around this as a community. You may have seen the USA Today article a couple days ago that said, you know, we've figured out cancer, sort of, we figured out heart disease, sort of. Why can't we do the same thing with the opioid crisis? And the reality is that this is far more complicated. You know, opioids, first of all, involve criminal activity. Second of all, they're a problem that cannot be solved only within healthcare. And you could say the same of heart disease and cancer, but the fact that opioids are much more cross-sector makes it all that more challenging as a problem to solve. So tonight as a teaser, I'm going to out the date now, March 12th. We are tentatively planning an evening event here in Brighton School somewhere. We're going to be hosted by Dr. McGowan, Chief Henderson, Supervisor Maley, and other panelists. Hopefully we'll come together. We're still in the planning stages of that. But we'll do another more extensive discussion on that evening. So I hope tonight interests you just a little bit to make you want to come back. But I'm going to provide a short overview on opioids, talk a little bit about addiction, talk about overdose and how those are different entities, and then talk a little bit about what we've done in the county, and then hopefully send you home with a little bit of homework with some things that you can think about that you can do both here in the school as well as in your homes. So this is all the physiology I'm going to say tonight. The physiology here is that the opioid system in our body is normal. Okay, we all have an opioid system. We need it. We need it to do a whole host of normal physiological things. We alter the opioid system for various medical purposes. So you take medications for pain, you can take medications for cough, for other illnesses, and it's a normal part of our body. The problem, though, is that the opioid system is also associated with pleasure, and that is what makes any medication or any substance that impacts the opioid system potentially addictive. And so addiction, the first take-home point I want you all to go home with is that addiction is a chronic illness. It is not unlike diabetes or heart failure or any of the other medical illnesses, depression, that you might know about. You know, I want to emphasize, I know that there's a lot of stigma around addiction. It is not a choice. People don't wake up one day and choose to have an addiction. Okay, this is a chronic illness. It is an addiction, it is a disease where there's drug seeking, compulsive use. It impacts behaviors, relationships, school, work, home, emotions. And people who have an addiction generally know it. They generally want to get out of it, and they struggle. And this is where we, in the medical field and in other sectors, need to show compassion and love, because this is a very debilitating illness. And as I mentioned, it's not an indication of one's spirituality or moral composition or any of that. This is truly an illness. The fact is that anybody can become addicted. And this is why I think it's so important to talk about it in the schools, because we know that our genetic background makes up about half of the risk that predisposes us to addiction. And then about the other half is environmental. The most highly predictive of the environmental factors that predicts addiction is early exposure. And this is true of any substance, be it cigarette smoke, opioids, gambling, other types of addiction. The earlier the exposure, the more likely that child will develop addiction in the future. And so that's why it's so important. And one of the questions we always ask is how common is it among our students? Truth is, we don't know, but we know it's not zero. And we know that any child that we might hopefully never lose, but if we lose a child to addiction, will be a tragedy. And we have lost kids to overdose here in Monroe County, and every death is really a tragedy. The impact, I hope I don't have to share with you too many details. What I'll say about this is that the largest impact that I've been impressed by is the human toll. When I hear stories of people who've lost loved ones, the average age of overdose in Monroe County last year was 36 years old. And that's not death, that's overdose. But when you look at the mortality, it's roughly the same. And so we're talking about people in the prime of their life. And it is absolutely devastating to hear the stories of loss among families. The economic cost is enormous, $120 billion in lost productivity annually for total drug abuse. Prescription drug abuse is about $55 billion annually. We know that about 1 in 10 children in the U.S. is exposed to addiction and lives with at least one adult who suffers from an addictive disorder. And the majority of these kids are under the age of 5. So these are the youngest of our kids. And we believe that this is an underreport, but law enforcement has reported 6 overdoses in 2017. Every time there's an overdose, I get a tweet about it. So far, actually since Christmas, I've gotten about 20. So it's been a very dangerous cold spell for us. So in contrast to addiction, which is a chronic illness, I want to share a difference with you in terms of overdose. Overdose is a public health problem. Okay, addiction is a medical illness. Overdose is a public health problem because we know it's a problem that medicine cannot alone solve. When we look at the risk factors for overdose, these aren't things that we can necessarily impact from the walls of a hospital or a medical office. And this is where we really need to focus our efforts. We need to focus on all the sectors that might impact the risk factors for overdose. I won't go too much into why we have the overdose epidemic, other than to say it's extremely complicated. A whole host of medical factors, economic factors, trends. The one thing that I will say is that here in Monroe County, we've done a much better job decreasing the amount of prescription opioids that are on our streets. Unfortunately, what that's led to is that because we haven't yet cracked the addiction nut, people are turning from prescription opioids to other opioids, and that's the problem right now. People are going to the streets, finding heroin, and unfortunately what they think is heroin isn't always heroin. And so that is why we have the lethality in the overdoses now. So it's in mixing heroin with other things. People don't know what they're using, and by and large, people don't intend to commit suicide. People die by accident, and that's what makes it all the more tragic. So this is the beginning of your homework. First, I want you to learn about naloxone. Naloxone, or Narcan, is the antidote to an overdose. Here in New York State, you can get this without a prescription by going to any pharmacy. Okay? It is very easy to use. It is 100% safe. If you use it on a person who's not overdosing, nothing will happen. Okay? If they're overdosing from another substance that's not an opioid, nothing will happen. But if they happen to be overdosing from an opioid, you can save their life. And I can go into details of how it works. But basically, it is completely safe. You're protected by the Good Samaritan law. If something happens to go wrong when you try to do this, you're completely covered. And really, there is no reason not to try. It's easier than using an EpiPen. So those of you who've used an EpiPen, that is scary. When you use an EpiPen, you've got to send the person to the ER. If you use Narcan and nothing happens, or if they, come to, it's not as dangerous nearly as epinephrine is. And again, we'll talk about this more later on, but here in the county, we've really stepped up our efforts to try to combat this epidemic. You know, for one of the things that we're trying to do in the health department is to convey the message that addiction is a chronic illness and that overdose is preventable. If there's nothing else you come away with, I want you to know that addiction is a chronic illness and overdose is preventable. We're really trying to step up our efforts around education. We're training as many groups that we can on how to use Narcan. We've expanded our medical examiner's office. We're going to have a training program to train forensic pathologists so we can expand our ability to manage all of the toxicology and the post-mortem evaluations that we need to undertake in the medical examiner's office. And probably later this month, I'll be announcing that we'll be convening an advisory panel to me to change and unify and standardize the medical practice across the county with regard to the emergency rooms. One of the bottlenecks right now is that all of the overdose victims are going to the ERs, and the ERs don't yet have a way to get them all to the right place. And so we're going to work on how to improve that process. And then the other big piece that we're working on is data. So you may have seen in the newspapers that there's a lot of confusion and disagreement around the data, and that is the hardest part about it. The data that are reported to the New York State Department of Health partly come from us, but they're incorrect, they're delayed. It takes our medical examiner's office usually about 6 to 7 months to process from start to finish an overdose death. And so there's always going to be a delay in the processing of data. And so what we're trying to do is develop a data set that's more actionable so that on any given day, my staff can go out to the corner of whatever and whatever. And if we know that there is a rash of overdoses in that area, we want to get out there and educate and try to prevent any future deaths. So this is really surveillance and epidemiology at its finest. So there's a lot more to talk about. The last thing I want to communicate to all of you is things that you might consider doing. Here in the schools, we want everybody to raise their awareness. We want to address the stigma. There's still a lot of stigma associated with addiction. And when I mentioned to some audiences that you can go to Walgreens and pick up a Narcan for free, many people have a lot of reservations about that because they worry about what people might think. And the reality is you're just trying to be prepared. Nobody can tell when they're going to be around an overdose victim. And if you happen to be around somebody who's overdosing and you happen to have Narcan, you could very easily save lives. I encourage schools to evaluate your support services in the schools, counseling. Consider stocking Narcan in your schools, and I think we do. And then consider having an informational forum, which we'll have later on. In your homes, look in your medicine cabinets. You would be surprised to what you'll find. Many people have unused pain medications from previous surgeries, procedures, whatever. Get rid of it. It's a time bomb. We know that there's a lot of the criminal activity around this is around theft of opioids. The thieves are very clever. They will follow the medical motors vans and look for people that get out in crutches or in wheelchairs and assume that they've had an orthopedic procedure recently, and they will go ransack your medicine cabinet. It is that sophisticated. Talk to your kids, talk to your loved ones. Try to make this a topic that's a little more comfortable to discuss depending on the age of your child. And then really consider whether it's in your home, in your workplace, in your place of worship. Consider whether Narcan would be appropriate to have in that location, because you really only need one or two, hopefully, and that might be all you need to save a life. So with that, I'll open it up to questions. There's a lot more we can talk about, but I wanted to make sure that we left some time for questions.
Did I hear you correctly? You say Narcan is free?
It can be free. So there's a new program called the Naloxone Co-Payment Assistance Program, NCAP, that was just passed last summer, that allows the pharmacy to bill the state up to $40 of your copay. So you would go in as if for any other medication, and depending on your insurance, you may have a copay. Most people don't have a copay. Well, you might now, but up to $40 of that copay will be covered by the state.
And so you don't need a prescription, or
You don't need a prescription. There's a standing order across the entire state. So you just need to go in, and they'll give you a short handout that talks to you about how to use it. We'll be putting out a video on YouTube probably later this month that also goes into how to use it. But if anybody's used Afrin spray or Flonase, it's that easy.
I just need to let everyone know, because of the recording, any questions that may be personal will be cut. We're going to do the majority of our question and answer at the end so that the recording ends, and then you are much more free to ask questions if they are of a more personal nature. So I just want to give you that heads up, okay? Any other questions right now before we go on? And otherwise, then we'll have an open time at the end. Okay, thank you, Dr. Mendoza. And as he said, the district has a meeting in preparation with Dr. Mendoza district-wide, talking about this much more in depth and more thoroughly. So you'll get lots of information about that coming up in March, and we'll let you know. Hopefully you'll be able to come out with that. Our next speaker is Dr. Miri Arie, and she's going to be talking about the anxiety that our kids suffer at all age levels. So thank you.
So a little change of schedule. I'm Laura Tomaselli. I am a child neurologist and a pediatric sleep medicine provider at U of R, and I think this is a good combination of talks today, because I'm going to talk a little bit about sleep and how sleep affects our teens, and also how sleep or lack of sleep is related to anxiety or making decisions about using substances or those kinds of things. So I'm going to start out talking just a little bit about sleep so we can understand, we're all on the same page just about what regulates sleep, and then a little bit about how things change in teenagers. We have lots of data that tells us that the physiology of a teenager's brain changes after they go through puberty, and that affects how they sleep. And so a lot of the, what seems to us maybe crazy schedules they keep, isn't really just social media or choice or just wanting to hang out and not sleep. There's really biology behind it, and that's an important thing for us to keep in mind. And I'll talk a little bit about so how that affects their total amount of sleep they get, and sleep deprivation, and how sleep deprivation can affect the health of teenagers and us as adults as well, but now we're focusing on the kids. And then something in particular, things that can be done to try and help kids get a more sufficient amount of sleep, and what changes we can make so that we focus on the things that really can make a difference, and then some recommendations about from some of the bigger medical societies about things that should be done to do the best for our kids. So I'm going to try not to do too much also physiology here, but like I said, I wanted to start out just talking a little bit more about sleep. And so sleep, the amount we sleep and being awake versus being asleep is basically regulated by two major systems. We have our circadian system and we have our homeostatic system. So the circadian system is that we all function on about a 24-hour cycle. And there are things in the environment that cue that system to keep us on that schedule. Nobody's exactly at 24 hours. Some people are a little bit shorter, some people are a little bit longer. But things like sunlight, or light in general, but sunlight most importantly, is something that regulates that rhythm. That the main clock, the main internal clock we have is in our brain. And the other thing that helps regulate it is something called melatonin. And that's going to come up again in a second when I focus a little bit more on teenagers. But that's one of the systems that helps us to be awake when we're supposed to be awake and sleep when we're supposed to sleep. So the homeostatic system, is that basically our brain and body always want to be just right. So we always want to have a homeostasis or an equilibrium, which means the longer you're awake, the longer your brain is awake and active, the more of a drive you build to then want to go to sleep. There's actually a chemical that builds up in your brain the longer you're awake, and when you hit that sort of critical point, it makes it easier for you to get to sleep at night. And then the reverse of that, the longer you're asleep, the more that chemical dissipates and the more of a drive you have to then be awake and start your day. So these two things work together to keep us functioning in society and be able to do what we need to do during the day and get a good night's sleep at night so we can get the rest and recovery we need and get ready to start our next day. So the important thing about adolescence is once we go through puberty, as we all know and have experienced with our children now currently, there's lots of changes to hormones and all kinds of different things going on. And there's this, what we call progressive owl tendency as kids pass through puberty and get older and go through their teenage years. And so tend to be more night owls and prefer to be up late, and then in reverse to that, or to accommodate that, sleep in longer in the morning. Part of this is because their melatonin, which I talked about before, the hormone from the brain that's secreted at night to tell your brain and body that it's time to get ready for sleep, they secrete theirs later, so they're just not ready to get to sleep until later. So again, that's one of the key driving factors, saying it's not their choice to stay up late, it's kind of innate into their biology, and so they can't get to sleep at an earlier time. And then also, we think that their brain doesn't respond as quickly or as easily to those external factors, so sunlight and melatonin. So their brain needs to be awake for a longer period of time before they realize that I really need to get myself some sleep. So these things come together in teenagers to make their preferred bedtime and wake time delayed or shifted, so that most teenagers really can't go to sleep much before 11 o'clock, and a lot of them are going to sleep a lot later than that. And then wake up 8 o'clock or later. And so all these things together are kind of setting up the teenagers for a struggle, because one of the important things that I always find when I see patients in my sleep clinic is their patients and parents alike are absolutely amazed when I tell them that you still need at least 8.5, more likely 9.5 hours of sleep every night. I think as parents, we tend to think that, well, they're kind of just like adults. They're getting there, so really they probably just need the same amount of sleep that we do, 7 to 8 hours, which probably a lot of us don't get that maybe. But we kind of think that they don't really need that much sleep, but they do during this important time of growth and development. And so we're really setting them up to start out behind the 8 ball, to not be in a good place to do what they need to do during the day, because we have this coming together of their biologic changes, which makes them not get to sleep until late. They also have lots of demands on them, social, extracurricular things we're expecting them to do. Those can be modified some, but they're all real demands. We all have very busy kids and very busy lives. But then we impose upon them an early wake time to have to be at school by 7:45 in the morning. And so if they're not going to sleep until 12 or 1 o'clock, then there's no way that they're going to be able to get enough sleep that they need to function properly. And so as the week goes on, and each day they're getting insufficient sleep, by the end of the week, a lot of teenagers are really sleep deprived and really feeling pretty crummy. And that leads to, I'm sure if you have teenagers, a lot of you know, weekend oversleeping. So they still stay up even later on the weekends because that's what suits them and that's what they like to do. But then they wind up sleeping half the day away, or at least most of the morning, because they're trying to make up for the sleep they missed all week. When that's really, that erratic schedule really isn't healthy for a brain to function at its best, even on the weekend when you're getting a lot of sleep. A lot of times they still feel what we call brain fog or sleep inertia, where they wake up after 12 hours of sleep and they actually feel worse than they do during the week because their brain is just wanting them to get more sleep and they can't. So it really sets up kids for not functioning at their best during the week. And so there's been a lot of surveys out there, a lot of self-reported measures from teenagers. The National Sleep Foundation does a lot of these things, and there was so a little bit of old data, but this is the best, the most detailed report that we have at this point. There's certainly more to be coming. Back in 2006, but on average, adolescents reported sleeping about 7.5 hours. But if you looked at that, if you divided it up amongst ages and grades, the 6th graders or the younger teenagers were getting a decent amount of sleep, whereas the 12th graders were getting less than 7 hours at night. And so it's a pretty significant problem, with about 45% getting less than 8 hours of sleep at night in these self-reported measures. Other things they reported on were that about almost a third of them reported that they're falling asleep in school weekly. 1 in 5 reported that they're falling asleep when they're doing their homework. And about 14% are reporting that they're either arriving late to school or totally missing school because they can't get up. I've actually had patients in my office with parents telling me they've called 911 because they're convinced their child is in a coma because they can't wake them up to get them to go to school, and that I need to talk to the school to tell them that their child has a real problem here, which it is a real problem, but that this is something where I've had families have CPS call them and those kinds of things because they're not getting their kids to school. So it is a real issue, and it extends through all towns and counties and states and across the country. And it's something that is definitely causing a problem, and a lot of it too is just lack of information. Whereas in the same survey, 71% of parents reported that they thought that their children were getting sufficient sleep, but we saw from the previous slide that maybe only about 25% are actually getting sufficient sleep. So it's an important thing that we keep educating ourselves about. So there's lots of negative consequences, and I'll move through this a little bit more quickly. Sorry, I tend to over-prepare for things. And so one of the really important things when we're here talking about school is that sleep deprivation really affects the higher level executive functioning in teenagers during a time where those things are supposed to be developing and growing, and they're supposed to be learning these skills, where when they're sleep deprived, they're set up to not make such great decisions. So poor judgment, problems with attention, focus, and increase in risk-taking behaviors, things like substance abuse, are more likely to happen when teenagers are sleep deprived. There's also studies that tell us that it certainly can affect grades and test scores and just overall decreased readiness to learn. And these are some more of the surveys where basically children that report that they get sufficient sleep also report that they have better grades, that they're more ready to learn, they get better reports from schools and teachers, and those that struggle to wake up in the morning suggesting their sleep isn't good are not as ready to learn and do not do as well in school. And oftentimes it leads to use of things, stimulants, caffeine, prescription stimulants, things that in the moment can provide some relief, some benefit in improving the sleepiness, but over the long run, these things are certainly not, cannot make up for the sleep that's being missed. And also the studies do show us that there's increased risk of substance abuse later on when these things are used more in adolescence. There is a big association with sleep deprivation and mood, and certainly we all know, we've all been through periods of sleep deprivation for whatever reason, and you're certainly more on edge, more irritable, more quick to make rash decisions. So anxiety, depression, withdrawal, sort of going into yourself, and again, increased risk-taking behavior have time and again been shown to be related to sleep deprivation. So obesity, another epidemic, if you will, in public health, and sleep deprivation has been shown to be a significant factor related to obesity, because when you don't get enough sleep, your sympathetic nervous system, which is basically your fight or fight system, goes into overdrive, and it causes, affects hormone levels, it affects blood pressure, it affects heart function, insulin, glucose, all kinds of things. And also, when you're sleep deprived, there's a confusion. People often will mistake feeling sleepy with feeling hungry, and so they'll eat food to either keep themselves awake or just because they think that's what they need in the moment. On top of that, people also tend to make poorer decisions when it comes to what they eat when they're sleep deprived, so choosing more carb-rich foods or fats or processed foods. And so there's definitely an association there with the sleep deprivation and obesity. More significantly, immediately important is drowsy driving, and that's a huge issue for teenagers, especially in the morning when they're waking up earlier than their brains and bodies are ready for that. And information coming from the National Highway Traffic Safety Administration tells us that in particular this is a problem for people 25 and younger, so new drivers and people that are more likely to be significantly sleep deprived. About 50% of the fatal or serious crashes related to drowsiness are involving young drivers, and that when asking teenagers how they feel when driving, going back to the National Sleep Foundation poll, over 50% reported feeling sleepy while driving over the past year, and 11% reported having an accident in which sleepiness was the main cause. So when I see patients in my sleep clinic, this is a clinic that are of driving age, this is the most serious thing that I have to talk to them about. And I have lots of patients reporting to me when I'm talking with them that yes, they do feel drowsy when they're driving. So one thing that we can do about that, so according to the AAP, a key modifiable contributor to insufficient sleep is early wake times in school. And so that's something we can change and we can do something about to help kids be able to have more time in bed to get a more sufficient amount of sleep. And I know one of the main concerns is that, well, we're going to make these changes, we're going to put in all this effort, and nothing's going to change for the teenagers. They're just going to stay up later, they're not going to get any more sleep. But delaying school start time has happened in a lot of communities, and it's been successful. This is a study that was looking at Minneapolis public schools, and the University of Minnesota did a study, and these are just these are general findings. I'll talk a little bit more specifics on the next slide, but what they did find was increased total sleep time, decreased absenteeism, improved performance on tests, fewer automobile accidents, less reported depression. And so this was a public school system that had 18,000 students. They made a really big and bold and wonderful change from 7:15 in the morning to 8:40 in the morning. And really what the AAP and other medical societies recommend is if you're making the change, it should be after 8:30 to really make a difference. And again, they found that on average, the children gained an hour of sleep, which is a significant improvement from what they were getting before. And this is another article looking at some other school districts over the past 10 years. At least 70 other public schools have made the change, and they've been successful. And that number keeps increasing. I was just at the Pediatric Sleep meeting in November where a provider out in Seattle was talking about the change they made at the Seattle Public School District, which has a lot of schools, 15 high schools, 13 middle schools. In 2016, they made the change, and she reported that certainly nothing goes without bumps in the road, but they had a successful year and that there were not any significant negative consequences or fallout from the change, and the school was functioning well. This is one that I picked because it seems kind of similar to Brighton to me. 4,300 students, 5 schools total. The change was made back in 2003. Original bell time, 7:35. For middle school, high school, elementary 8:15. Basically, they did a flop there, and so high school and middle school 8:15 now. Not ideal, but definitely better than what it was, and it was successful. Kids got more sleep since the change wasn't that big. There wasn't that much more sleep, but students were feeling better and doing better, and it did make a difference for them. So talking about that study that looked at these 70 schools that made changes in the past 10 years, the top benefits were increased attendance. They actually reported cost savings. I didn't go into detail of that. That's something for another time, but some of them did report some savings in making the change. Reduced tardiness, improved test scores, improved grades. And they actually reported too that many districts found that more students participated in extracurricular activities, and that sports programs actually grew, because I know one of the major concerns about school start time changes effect on athletics, and that has not been found in any of these 70 schools that this paper is talking about. And actually teams perform better because the athletes were sleeping more. They talked about cost too, and really the biggest point that they made that I thought was really important is most of the concerns that were raised by the school districts prior to making the change never actually happened. So the fear of the change was the bigger issue. The change itself really did not cause significant problems on the schools, and you can see there no canceled or significantly affected programs, no loss of support, those kinds of things. The one thing that they did perceived cost they felt was largely on families, which is I know a concern, but having families have to adjust work schedules to try and accommodate the changing of the schedule. And there were some costs in some of the districts. Some costs did fall to the family, but that was not a common finding. So overall, just some recommendations. So Center for Disease Control looks at insufficient sleep as a substantial public health concern, and they made it part of their Healthy People 2020 as an objective to increase the proportion of students 9 through 12 who get sufficient sleep, which they put here as 8 or more hours. Really, it should be like 9 hours, but 8 is definitely better than what a lot of kids are getting right now. American Medical Association, I think this was from 2016, they adopted a policy statement as well, calling on districts to implement middle school and high school times no earlier than 8:30, and American Academy of Pediatrics 2014, same thing, urging middle school and high school to aim for start times 8:30 or later. And so the main points are that, I think, are that teenagers are sleep deprived, they're not getting enough sleep, and there's a lot of negative health consequences as a result of that. And it's not just by choice. There's things about their physiology, their biology that makes this happen. And so we need to help them out and try and change things that are changeable. And school start time is one of those things. and that consistently across the board, the changes that have been made have been successful, and the concerns prior to the change have been the bigger issue, and then when the changes actually happened, most of those have not been actualized. And that's it, thanks.
I have a question.
Yeah.
Has there been any studies about the prevalence of caffeine with kids now? When I was a kid, it was an adult drink. Now everybody's going to Starbucks.
Right.
I
think Starbucks is part of the problem.
I think it is mostly a part of the problem.
But no, I don't have any numbers, but I certainly can tell you that in my practice, the majority of the teenagers that I see are telling me that yes, they're having caffeine, not necessarily every day, but majority of the days during the week. Just from my experience, from what I see, I would say yes, that it's definitely on the rise, but I don't have numbers to back that up.
What do you consider teenagers, or what are kind of the age ranges and going up to what age?
So we kind of use a standard of, when we're looking at sleep things, adult of 18, but really I would say that I'm still talking about into the early 20s. Kids are still, I guess not really technically kids then, but still requiring 8 to 9 hours of sleep at night. And usually we're talking 12 to say 20, I guess is what I would say. I would say for
college years.
Yep, through the college years. And the studies that are on there is they looked at college students as well, and they have the same negative effects on academic performance and the different struggles. And then they also oftentimes struggle even more because they're now in an environment where there's much less regulation of what they're doing. And so it's definitely a problem. But I would say less than 12, sleep would be 10 to 11 hours at night actually, and then 12 through college years, that going for that 9 hours if possible.
I would say whenever I do research on the start times, it's certainly compelling. What I have trouble squaring it with is just in my own family, I have 2 middle schoolers, one who's an early bird and one who's a night owl. And for the early bird to change it later would actually be harder for him. So is he an outlier? Like, are there not early birds anymore?
Yeah, there really are. I mean, there certainly are some, but the norm is night owl in the teenage years. I don't know what are the ages there?
They're both 11.
Oh, okay. Oh, so they're twins?
No, but
Okay. So yeah, the norm is more of a delayed sleep phase. Certainly there are kids that are, I'm not seeing them in my practice because they're not struggling, but there are kids that are more early, still in the middle school years, I would say, but definitely once, and I don't know, with puberty and those kinds of things, we're more than likely going to see a change in the other direction. And I would say that even for somebody who's more of an early bird, they may have a little bit more time before the early start time of school to get other things done, or do work or a program or whatever before school. But I think still, the end of the day is still going to be a reasonable end of the day time. It's not that they're going to be at school to all hours.
yeah, no, I don't have a problem with that. It just doesn't square with what I see in my house. I'm trying to figure out if it's just really weird or.
It's so, there are certainly things that we typically see, but I see young kids who are night owls, and a lot of it has to do with what kind of runs in the family, genetics, a lot of different things come into play. But the norm is, as kids get older, more towards puberty and then adolescent years, they tend to progress onto this night owl kind of schedule.
I'm just wondering, I have an early bird as well, and now I'm wondering, maybe he's just forced himself into this to comply with the schedule, and I wonder, are there any health consequences long-term to that, to disobey your circadian and the other rhythm?
It's more it's something that is hard to do, it's hard to keep up, and it's something you have to consistently work at to sort of live outside of your typical circadian rhythm. But as long as the sleep is still a good amount of sleep and the sleep is good quality, sometimes when people function outside of their typical rhythm, the sleep can become more disrupted because it's not really what their brain wants to do. But if he still or she still feels that sleep is good and is getting a total amount of sleep time that's appropriate for age, then it's okay.
How do you define quality sleep? You just mentioned a little bit. Because a child can say, I was in bed for so many hours, waking up every hour to
Right.
bring to worry about life and stuff.
Yeah, so everybody has arousals during the night when we cycle through our different sleep stages. People that are decent sleepers, that are good sleepers, have no recollection of having the arousals. They just kind of change position or not and go back to sleep. And so that to me is a good quality sleep where it doesn't take you more than 15 to 20 minutes to fall asleep. You think you sleep through the night, maybe you're aware of waking up once, but you're not awake for a long time, and then depending on your age, you're waking up at that many hours later, appropriate for your age. For kids that have poor quality sleep, they're the kids that are saying that they're laying in bed forever, they can't fall asleep, they're waking up multiple times during the night. Once they do wake up, they have trouble getting back to sleep. And those are things where we would start thinking about other things, maybe going on sleep disorders, obstructive sleep apnea, restless leg syndrome, other kinds of things. Anxiety certainly is a big contributing factor to poor sleep. So those are the things that we would think about.
Thank you. And if there's other questions for Dr. Tomaselli, we'll have time. Oh, there was one more, sorry.
Yeah, but it can wait until afterwards if that one is that's fine.
Okay, thank you. Now, Dr. Reed, thank you y'all for being patient and adapting to the technical issues. I appreciate that.
So my name is Miri Arie. I'm a child psychologist. My practice is about, 70% kids with anxiety, all different kinds. The rest of it is mostly social skills, typical parenting, things like that. They are oftentimes overmixed. I'm going to present something quite simple. Life is never as simple. It's 8 o'clock. If you've been listening for a long time, it would be great if you could make it conversational. So I'll ask questions. Feel free to jump in. I'm okay with you asking questions as we go and not waiting to the end. I think it's just going to be easier at this time of the night. So what is anxiety? Throw out words that come to mind. Worries. Stress. Feelings that come to mind? Restlessness. Okay. What's the difference between feeling scared and feeling anxious? Is there a difference?
About being scared.
What does it mean to feel scared?
When we're really, really worried about something and you're worried about being worried and you can't stop.
Okay. Other ideas?
Scared of something. Anxiety is more of a amorphous. You can't really define what you're anxious about.
Okay. So, I think I did pretty well with guessing. Fear is a big one. The common, I think that the general agreement to differentiate scared and anxiety is that I'm feeling scared at the moment when there is a current trigger, stimuli, something that presents danger to me. It would stimulate my fight, flight, freeze response. I would need to do something to take care of myself. We use the term anxiety when we worry about things that might happen, so it's future focused and not present focused. And actually, most of our feelings have a purpose, right? When we are happy of something, what does it mean? We want more or less of that? More. We want more, right? If something is disgusting us, what we would want to do? Stay away from it. If something makes us sad, we just want it to stop, right? Anxiety tells us stay away, take care of your body, okay? What happens with anxiety is that when you're afraid, when you're scared too much, and it's not predict danger anymore, okay? So it's constant, it's ongoing, our planning is not reflecting reality anymore. And our body is basically in a constant false alarm state, okay? Stress, something you said before. Something important to note about stress and anxiety and nervousness and fear is that some amount of it is really healthy. So being worried about how many people be here tonight made me to rehearse, made me to present it and get feedback. If I worry too much, I won't be able to talk. I would be too nervous. I am a little bit, but I think it's manageable. Question, thoughts so far? Good. Okay. When we talk about anxiety, the simplest way to talk about it in my mind is to think about it as a triangle, which each corner corresponds and goes all directions. So let's think about me walking down the street and seeing a dog. If I have the thought that that dog gonna bite me, or I'm sure he's gonna bite me, it's gonna evoke a physiological response in my body. If I'm really anxious, I would be aware of that. My heartbeat's gonna raise, I might be shaky, some people feel that they are getting more warm, etc., etc. Usually there is a visible sign that you can say and label it. Oh, you look scared, you look feared, you look anxious, whatever it is, right? If I think that there is a danger, it would guide my behavior. I better run, or if I'm still home, please stay home, right? When I escaped from the danger because I stayed home, what did my brain learn? What's the conclusion of this cycle? Say it again?
Avoidance.
So what did avoidance teach me?
To be afraid of it.
Right, how did I learn to be afraid? Oh, you're safe. That was the right action to do. You kept yourself safe by staying home. If I would have gone out, I might have learned that I was still safe. But my brain would never learn that, because I put myself in positions that there is only one learning possible. Okay, make sense so far? So going back to the triangle, typical thoughts are different kinds of what-ifs. There are very well-known, well-documented thinking biases that contribute and maintain anxiety. We oftentimes misattribute risks. We believe that things that could happen are more likely to happen versus things that they are not very high. So when you guys go into the car, does any of you worry about what if somebody gonna hit you? Not really, right? But actually the likelihood of getting in a car accident is much higher than being hurt by a spider or getting stuck in an elevator or being attacked by 10,000 other things. But we don't think about it, so we feel safe. If you think about things that are not as dangerous, your system is being evoked. What I hear a lot from my parents that I work with is that their kids have really good argument. But what if it happens? We cannot guarantee that something cannot happen because we're not working in 100% guarantee world. So it oftentimes makes parents having challenges to talk with their kids because they feel like they need to promise something that they don't want to promise. So that's mostly what I want to say about thinking patterns, unless anybody has questions or comments. Okay. Physiological components. So this is the part that we cannot control very well. It's our sympathetic nervous system, which Laura mentioned before. Different people would have different symptoms. There are some people who are really, really good blocking their awareness to their physiological symptoms. They don't feel scared, but they can go to the bathroom. They don't feel scared, but they feel bored. They don't feel scared, they don't feel nervous, but other things. And there are people who are hypersensitive. So those who have stomach aches when they go to school, those who have headaches, those who just really literally freeze. So there is some variance with that. So we oftentimes, when we say feelings, we need to make sure that we think about the physiological components of feelings and not only the labeling, okay? Behavior. So this is what we talked a little bit about avoidance, that the natural cycle is when the natural response is when you're sure that there is danger, is to avoid it. It's a safety mechanism. There are another thing that is a little bit less known, but it's present, is those safety behaviors that we do that buy us fake confidence, like going with a water bottle just in case I would need it, right? There is nothing wrong with that. If it helps me survive, why not? If that allows me to break avoidance cycle, that's good. But it's keeping to those would prevent the recalibrating of the brain that is needed as part of treatment of reading reality right. In the sense that I know what really predicting danger, and I can say, okay, this is a worry, but I know that it doesn't predict danger. Okay? Thoughts, questions? Too fast, too slow? We're good. Good. We talked a little bit about avoidance. If there is one thing that I would encourage you to leave this talk with, is to be aware that there is nothing you can do to treat anxiety without breaking avoidance cycle. It's the hardest thing to do. That's the only thing that's going to work. There are different pathways, there are different stages, but if your child is not going to be exposed to the things that they fear the most, it's not going to go away. Okay. So this is an invitation to take what I've said so far and put it on a real life example. Anyone cares, interested to have a more relevant example than a dog? Yeah.
My third grader has some anxiety around his homework, doing it correctly, getting a perfect score or close to perfect score. And I see that it's interesting, this thoughts, feelings, behavior. I see this kind of triangle pattern happening. And I remember, so when they announced that Brighton schools were closed for the snow day, he was studying or doing homework and studying, and he said, well, just do my homework just in case they change their mind and say school. And I said, there's no chance of that. School's not, they're not going to wake up and say, just kidding, you have to go to school.
We're definitely not going to do that.
Definitely not. But that was the anxiety that drove him to do his homework on a Thursday night when he really had until Sunday night.
Okay. Are you okay with us using that example for the next slides? All right. So, what do we want? We'll call your son Joe. It's okay? So if we want to help Joe overcome his anxiety, one thing I haven't said is that we kind of use the word anxiety loosely. Not every child who is nervous has anxiety disorder. Okay, when do we start to call it anxiety disorder? Is when it's too much, when it's never stopped, when it interferes with their functioning. If they have anxious temperament, if they are warriors in general, but they still do what they need to do, we wouldn't call it a clinical disorder. Okay, so keep it in mind. Still, as a parent, you can do something to elevate the symptoms, even if it's not clinically defined as anxiety. So in this case, if we want to understand Joe, how would we understand the anxiety? If we want to go back to that triangle, what are the thoughts that might be there? What are the worries, the what-ifs? You mentioned some.
What if there is school tomorrow after all, and I go and I don't have my homework done because I thought it was a snow day?
So what if I'll make a mistake? What if I won't be prepared? What if somebody gonna notice that? What if somebody gonna be upset with me? What if somebody in my class may do better than me? All of those are the thoughts. What would be the physiological, emotional responses that he might have? You guys are welcome to guess. When he sits there and does his homework and can't let go and go play in the snow or sit by the fire, what does his body sense? What does his brain sense? Signals?
What he's panicking, he's got to make sure it's done.
Okay, right. That's a behavior. What's inside? What's the physiology?
Stress, cortisol.
Tension, right?
Heart rate increase.
Heart rate might be faster. General tense, narrowing of mind, right? Usually when we're not anxious, we can think about all sorts of things. Now we are kind of single focus vision. The behavior is get to safety, get to the high standard that nobody can reach, as if that would elevate anxiety, right? So that's the situation. So what do we do? Oh, let me go back. So we understand what's going on pretty well. Now we want to help him get some relief from those symptoms. So I'll talk about what you can do in each of those corners, because either corner you intervene gonna be helpful. You need to know that it's gonna start the cycle backwards, but we need to cover all corners to have a complete, comprehensive intervention. Sometimes you would learn that part of the anxiety is because really kids are lack of skills. And it's not about treating anxiety, it's about helping them get to where they need to be so they could be successful. So sometimes that's needed. We didn't talk at all about why kids have anxiety. So I'm gonna say it here real quickly. Some of it genetics, some of it is environmental. Okay. So when you're panicking or when you have anxiety, you need some way to calm down. As a child with anxiety, you cannot calm down on yourself. So you need someone to help you calm down, externally regulate you, later on co-regulate you. Now, if your parents are also anxious, and if the child triggers their parents' anxiety, we are in this vicious cycle that anxiety just grows. So sometimes part of the intervention is for the parents to make sure that they know to regulate their own anxiety for the sake of their kids. And as anxiety runs in family, it's not as easy. It's easily said than done. Sometimes overcoming anxiety and breaking avoidance cycles means that I need to take tiny steps, which means I cannot do business as usual. So my environment needs to change to allow me just tiny steps and let me feel the success of achieving small thing, which is far from where the rest of the kids are, but at least it's better from where I started. And by those gradual mini steps, I can get to where I need to be. But for that, the environment needs to be very accommodating. Yes?
Quick question, to make sure I understand. Back to Joe. Would you say that over-preparation is a kind of avoidance? Is avoidance the uncomfortable feeling of failing, like, this one homework assignment, who really cares? Right. Is that a type of avoidance behavior?
That, if we want to be accurate, that's a safety behavior. So there were two types of behaviors that kind of the byproduct. But you bring up a really, really good point. The biggest challenge, or for the positive, if we are able to teach it a child, and it's the biggest barrier, is that people with anxiety are very sensitive to feeling discomfort. So for them, discomfort signals danger. And once you're willing to feel discomfort and not making it more than what it is, you can tolerate the feeling of anxiety and let go. So being overly prepared is oftentimes not to feel that discomfort of the maybe, right? So there is a clinic in New York, and they have a beautiful slogan. For them, anxiety is learning to be comfortable with feeling not comfortable, right? But that's exactly what we need to do. Okay. So what are the specific strategies for each of those corners? The biggest thing with the cognitive part, with the thoughts, is realizing that thoughts are thoughts. It's an abstract thing that our mind creates. It doesn't necessarily a reality event. And if I can maintain this distance between what I'm thinking about and what's actually happening, I'll be much better off. Okay. A beautiful example or a metaphor is, think about you standing in a train station and think that each train is a thought. Okay. What if the teacher gonna catch me unprepared? What if I'm not gonna do well in exam? What if my friend's gonna make fun of me. All of those are a trait. Now, me staying on the station, I can choose to go on the train and start thinking, oh yes, what's going to happen, and trigger this anxiety cycle. Or I can say, yeah, I have a thought. Trains come and go. My thought going to come and go. Thoughts never stay. Try to think about one thing for more than a minute. Good luck. You'll have something else. So being able to stay in that passive position where you observe thoughts, not even trying to fight them, just let the brain do what it does, come and go, that would be a really good step. You'll hear people say mindfulness. What I've just said, this is part of mindfulness, okay? So in therapy, and it's helpful for any conversation with parents, making sure that kids know the distinction between facts and thoughts, facts and opinion. Thoughts can be thought of as opinions and not necessarily facts. There are lots of techniques about logging. So if I have a thought, what are the evidence that your thought is true? What is the evidence against that? That falls under this cognitive behavioral therapy. That's what therapists do when they work in that kind of work. Relaxation. There are different ways to relax your body. So real quickly, we have two parts in our nervous system. We have the parasympathetic system, which is the calm, the nice, easy. We should be in that state most of the time. The sympathetic system is the fight-flight. Think of it as like a light switch. You can trigger it on and off either with different biological events in your body, with triggers, signals from the environment. Okay, it's risky, get ready. The fun fact about that is that you can reverse it from the sympathetic systems, so from the fight-flight, back to the parasympathetics by breathing. Okay, so if you maintain a really nice, steady breath, you will switch your systems. Here is the catch. If I have a cent in my piggy bank for every time I've heard parents say, I just told my kid to breathe and it didn't work, I was so rich. But I'm not. And why is that? Because all of us can run, right? Try running. If somebody's going to chase you, you're going to run. Now see you run 5K. That's not that easy. We need to build some tolerance and some muscles to be able to do that. The same way, using breathing efficiently to outlast the anxiety attack, that requires practice. So just breathing wouldn't help most of the time when the anxiety is severe. To do that, you need to do daily practices of mindfulness breathing to learn to activate this area of your body to trigger the parasympathetic system. Technology is wonderful. There are great apps to help you do that. Headspace is one of them. Sitting Still is one of them. Those are specifically geared for kids. There are plenty of others which I don't know in person. With young kids who have really hard time just to sit down and do relaxation, there are different games you can do with blowing. So try to blow bubbles in a steady pace for 3 minutes. It's not as easy as blowing bubbles, just blowing off candles. There are different little tricks. But breathing is a really crucial part in that system. Avoidance. I don't have good news. Just do it. Doing something is better. There is a whole philosophy. It needs to be well done. You cannot just overflow a child. You can't just, if somebody is afraid of being in an elevator, you can't sit there for 8 hours and good luck. It's not going to work. It used to be popular. It's failed. You have to do it gradually. Our body has something which is called habituation. It can get used to things that are very uncomfortable. If you'll take a rubber band and put it on your hand, a tight one, you will feel it at the beginning. Let it be, we'll forget about it. Our body gets used to it. the same way our body gonna get used to anxiety triggers. But we have to do it. No shortcuts. Questions? Thoughts? They have a question about it? Yes.
So, panic attacks, are they just a symptom of anxiety? How do they kind of get into that?
So panic attacks, they are much less common within kids. They start a little bit later on. Adolescents definitely have panic attacks. So if you'll think about the triangle, in panic attack, the physiological part is activated the most, and there is very little awareness to the thought process. But it's the same. There is some kind of a learning that some environmental trigger, something in the environmental triggers that system. It could be just random. We may not be aware of that. But what happens really in panic attack, that once you have a panic attack, you develop anxiety about having another one. And then the thoughts are already there. So the intervention for that is to reattribute the interpretation of the behavioral symptoms, not as predicting heart attack, but, oh, this is my anxiety. My heart is racing, but I'm not going to die. Right? Other questions?
Do you have any strategies for helping a child to identify what those thoughts are? Like, we postulated a whole bunch of things that somebody might be thinking, but then they're like, no, that's not it, but they can't even identify what those thoughts are.
Right. So it really depends on what the child age. As any learning, think about, a toddler who just starts to walk, right? If they fall, they look at your face to interpret the situation, right? The same thing happens with anxiety when you don't know. So your child is panicking or worried about something, they have no idea. You start to speculate. I wonder if, whatever, kind of multiple choice questions. What the research will tell you, and that's another very common concern, that kids not gonna latch on a suggestion if it really doesn't resonate with them. So you're gonna kind of offer maybe this, maybe this, maybe this. Something would stick eventually. Sometimes they need psychoeducation. They need to know that their tummy ache might be a way that their body is telling them something that they never thought about it. They were just overly focusing on their symptom. The best way to teach kids is really to talk about yourself. And to say, I'm noticing that such and such thing happened to me at work. I get nervous about it. I think about it. Here is how it presents in the body. So it's a lot of kind of planting seeds, and eventually they would learn to understand their body as a more holistic thing.
I'm wondering if I have a child who I suspect fear can manifest itself as anger, sometimes stubbornness, but he's really it's more about being nervous. I don't really see that.
So it's much more common for young kids with depression to manifest it as anger than sadness. So that's kind of a side comment. The control part is very different. If I'm walking around this world basically without skin, without proper feedbacks that tells me what's safe and unsafe, I'll better control my environment because everything that comes in feels as danger. So it's very, very common to describe anxious kids as bossy, over-controlling, rigid thinking, There are kids who are rigid thinking, stubborn, oppositional, without anxiety. So it's very, very tricky, but it's definitely there. Thank you.
Thank you. Sorry, I messed up your name, Dr. Arie. I apologize. Sorry about that. Do any of you have questions for any of our three presenters tonight? Feel free. Oh, and we're going to put an end to the recording. So I'm going to close quickly, and then you can continue and stay for a few questions if you have some. Anyway, thank you for coming out tonight. Our next Central PTSA board meeting is going to be February the 14th in this room at 9:15. Our next night meeting will be May 31st at 7 p.m. and it will also be here. If you have topics of interest or issues that you are concerned about and would like more information and perhaps another setting like this, please let me know. We are happy to try to accommodate those concerns for you. So feel free to contact any of us on the PTSA Central Board. Each building has building chairs as contacts there, or you can contact me. So anyway, thank you so much for coming out tonight. I appreciate our three presenters. It's been an excellent evening. Lots of great information.
This has been a special presentation from the Brighton Central School District's PTSA.